Hi, my name is Shannon Gray, and today I'll be examining your lungs, your heart, and your chest. First, I'm going to be inspecting like I do with any other assessment, looking at the size, the shape, and the symmetry of your chest. And then also looking for the respiratory rate and rhythm, looking for labored breathing, shallow breathing, along with use of accessory muscles or intercostal use, which I do not see. Also making note of your skin color, your superficial venous patterns, which may signal any cardiac vascular type of disease. The peripheral areas, which include the lips, the nails, for any cyanotic changes or clubbing. And it doesn't appear that you're in any respiratory distress of any kind. Next, I'm going to inspect some landmarks, which include the suprasternal notch. So that is going to be right here. Following that up for that midline to make sure that trachea is midline, it's not deviated. Following it down to the angle of Lewis, which is great for anatomical markings of that second ribs where they meet, and then following down to that costal region right here, which should be 90-degree angle or less, which yours is. If it was a hyperinflation of the lungs, such as emphysema, it may be greater than that 90-degree angle. And then now I'm going to go ahead and just kind of look over again for that precordium, looking for that PMI, which we would normally have the shirt off, but for the purposes of this video we did not. So looking for that PMI, so that's that fifth intercostal space, mid-clavicular line. We would look for any heaves, lifts, thrills, which I do not visibly see. And then next, moving to palpation of that apical. So that I should feel something very gentle, brief. The apical pulse should be less than 1 centimeter in diameter. And then while I'm palpating those borders, perfect. Just feeling for any further pulsations, heaves, lifts, thrills. If the apical pulse was unexpected, then at that point I might describe that as a heave or lift. So next I'm going to go ahead and check the borders of the heart. So that is done by percussion. So starting at that axillary area, percussing. So what we do is it should sound resonant, and then we go until we hear a dull sound. So we make a mark here, and then we move one intercostal space, and again percuss until we hear that dull, and then we continue to go on until we have those markings, and at that point we would be able to go ahead and measure that right sternal border. And so that right cardiac border should match up with that right sternal border. So now I'm going to auscultate heart sounds, and I'm going to have that doing while you are supine, and then we will have you sit up. So starting at that right intercostal space, second intercostal space to that left sternal border, moving over to the second intercostal space at that left side, left sternal border, moving down to third intercostal space or Erb's point at left sternal border, moving down to fourth intercostal space, which is the tricuspid area. And when I'm doing this, I'm listening essentially to the bell and the diaphragm. So I'm just, if I barely set my stethoscope on there, I'm going to hear. And then if I push down more firmly. And then moving to that fifth intercostal space, mid-clavicular line. Perfect. And so that's that apical area. So now I'm going to have you turn on your left side, actually while I'm on that apical area, if you want to turn. And that's going to bring that heart closer. So if we were going to hear any murmurs, that may be able to hear a little better. All right, you can go ahead and turn back over. So at that point, when I'm listening to the heart, I'm listening for that rhythm, noting the intensity, the variations, the splitting, along with concentrating on any systolic murmurs that I might have heard. So now I'm going to have you sit up, and then we're going to do the exact same thing with heart sounds. Perfect. I'm going to have you lean forward. starting at that second intercostal space at the right, and then moving over to that second intercostal space, the left sternal border, so that's the pulmonic, moving to the third Erb's point at that left sternal border, the tricuspid area, the fourth left sternal border, and then over to the fifth, which is the apical area at that midclavicular line. So that's going to allow me to hear any higher pitch murmurs. Next, I'm going to go ahead and palpate the chest for any subcutaneous air trapping. So I'm going to, and tactile firmness, so I'm going to have you say 99.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Perfect. So what I'm doing there is to make sure that I feel the vibrations symmetrically, which I do at this point. Now I'm going to have you go ahead and turn around. And placing again the palmar aspect, and then have you crossing. I'm going to say again,
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
And again, the same thing for the tactile firmness. Everything is symmetrical on the posterior side. So at this point, we're going to stay on this, and to assess for lung expansion, I'm going to place my hands around that 10th rib, bring my thumbs in so they are just slightly needly. So I'm going to have you take a big breath in and back out. Perfect. So watching that lung expansion to make sure my hands evenly go in and out, which they do. So while we are on this posterior side, I'm going to go ahead and also assess, and for that full lung expansion and lung extension, I do have tape, but again, this would be done on a patient with bare skin. We would do probably more of a marking than tape, but we will go ahead and measure it this way. So basically, we are going to go ahead and percuss down until we hear from that resonant sound down to a dull sound. So I will have you go ahead and take a big breath in and hold your breath. Perfect. And exhale. And then right where that area is, then I mark it here. And then at this point, I'm going to have you take a big breath in and then exhale all the way out and hold your breath out. Perfect. And then again, making a mark here. And then we would repeat it on this other side. I'm going to have you go ahead and take a big breath in and hold it. Perfect. And then we mark it. And then we're going to have you do the exact same thing. So I'm going to have you go ahead and exhale and hold that exhale. So on these areas then, at that point, we would go ahead and mark in centimeters what we are at. So he is at 4.5. So that is normal. Basically, we would want to be between 3 and 5. So that is good. So that is the diaphragm excursion. Perfect. Thank you. And then now we're going to go ahead and percuss. So we're going to do that front and the back. Every area should be resonant sound. I'm going to have you cross your arms in front. And again, so we can check that side. Perfect. And then we're going to do it on the other side. I'm going to have you turn around. Arms crossed. Perfect. If we heard a dull sound, basically that would tell us that we have a consolidation, so such as pneumonia. So everything should be resonant which yours are so far. Alright, perfect. And now while you're here, we're going to do this on the back, and then we will go ahead and change to that anterior aspect. So I'm going to go ahead and have you say 99.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
With that Bronkowski, I will anticipate to hear muffled sounds. If we heard anything that would have been very clear, again, we would anticipate that there might be consolidation in that area. I'm going to have you turn around and we're going to repeat it on that anterior side.
99, 99, 99, 99, 99, 99, 99, 99.
Perfect. And then while we're here, I'm going to go ahead and auscultate. So I'm going to have you take a big breath in and out as you feel me move. And last one. Perfect. And then I'm going to go ahead and do the posterior side while we're here then. Same thing when you feel my stethoscope, breathe in and out. So basically at this point I'm just listening for any wheezes, bronchi, crackling, which I don't hear. At this point his lungs are cleared auscultation, and just working in that ladder movement. Making sure that I get on that lateral side to make sure that I can assess that middle lung.